Hey there folks, so let's get back to the queue. It seems we have a lot of work to do today. I have already selected a abdominal CT scan. This is a female patient. She is 36 years old and I'm just going to download the images and share my screen. There we go, screen shared. Let me just turn off my speakers so you guys don't go nuts with echoing. Images are here. It's an unenhanced CT scan. Let's see what they say this scan is all about. It says she has pain in her left iliac fossa and it goes to her left lower limb. It's been 5 days like that. So does it make sense to you guys? To me it doesn't, but so this is all shaky from breathing artifacts and we're just going to roll the images and look for something suspicious. Unfortunately, this is a supposed acute abdomen, but we have no contrast enhancement and we don't have a proper scanned pre-contrast phase because it's shaky from the liver to the pelvis, so it's the worst case of a emergency CT scan. Unfortunately, this is what we have. This is usually what we have most commonly for CT scans. Unfortunately, it's really common for clinics and hospitals to care very little for emergency scans. It's usually just a money issue. No one really cares about any kind of quality control. Just scan and send them back to the ER, and whatever it can be reported, it will be reported, and it doesn't make a difference if you can actually make a proper diagnosis. In this particular case, I see some calcifications on the pelvis. These are not kidney stones, ureteral stones. These are just calcification, vessel calcifications. Usually veins, small pelvic veins, calcifications. This isn't a old scanner. It's clearly a new scanner, but it wasn't properly used. This patient has had her gallbladder taken out, and there are no signs of a left-sided disease whatsoever. The uterus seems a bit enlarged, but I'm not going to report that because it could be just normal for the patient, and maybe this is the appendix, but it's difficult to be sure because of the motion artifacts. And of course it said she has some sort of painful symptoms on the left, not on the right, so it doesn't really matter. So this is a normal scan, besides a missing gallbladder. So I'm just copy and paste my template and be on my way. Just finish it up and we can move on to the next one. Let's see, we have a left knee. Let's see, downloading. It says it's for osteomyelitis or osteomyelitis. It's bone infection. It's a left-sided bone infection, supposedly on the knee. Oh yes, this is something else. This really can't be good. Yeah, it's a major case of osteomyelitis for sure. Let me just do an MPR. Of course, they did no contrast enhancement. Oh, they did. They did a contrast enhancement phase, but I don't know. They did a very small quantity of contrast, almost none, which helps us very little. So, but I'm still going to do an NPR and see if it can helps us find out the margins, the limits of the fluid collection. So there are a bunch of fluid collections all over the bones, all around the body of the shaft of the femur. And let's see. Let me just fix this positioning. Yes, see, clear signs of bone erosion. Yes, multiple small sequestered fragments. There is air, cortical erosions all over the place, and we also have some sort of fluid collection on the soft tissue parts. It goes all the way to the growth plate, the diaphysis, and the metaphysis of this particular femur. So this is a epiphysis is also eroded. So this is a very severe case of bone infection, as said, as it is says, as they say on this exam request. Yes, you can see the margins of the fluid collections on soft tissue parts. This helps so I can properly measure them. And I'm going to measure as much as I can the site of osteolysis right there. So just going to write that down. Bone is 5.5 by 3.4. And let's see on the sagittal view. Maybe on the axial view, it's best. Anterior posterior might be best. Yes, anterior posterior 1.9, so 1.9. And here we can properly delineate. Oh, of course, they didn't scan it all the way, so it's another guesswork challenge, of course. Why would they skin it all the way if they can just skin like crap? And they did it twice. They skinned it twice the wrong way. There is a large articular effusion, and there is a periosteal collection that looks a lot like the bone erosion. So it's supposed to be pretty much the same. So just going to give them an estimate of the collection. It goes all the way to here. But soft tissues, it's 4.7 by 4.3 by 1.5. That's it. And let's just see if we can find any other disease. No, just the articular effusion, the edema of soft tissue parts. There is a site, probably a site of fistulization right there. It is right there. A small skin ulcer. Maybe this is a surgical incision, and there is drainage of the collection of fluid through the soft tissue all the way to the surgical scar. I suppose it is. This is a really terrible case of bone infection for sure. So let's describe it very really quickly so we can move on to the next one. So we are done. Let's move on to the next one. We have a CT of the abdomen. It's a female patient. Let's see what's up. Why we are. This patient has 2 CT scans, one from 1 week ago, and another one from one from 1 week ago and one from 1 week prior to that. So that, let's download both of them. It's some sort of advanced cancer patient, and they probably did a unenhanced CT scan, so this is quite possibly a useless scan, just one of those make-believe scans that the doctors ordered to have anything to say to the family when they can't do much. Because if you are staging a cancer patient, it makes no sense to do a unenhanced scan, because you won't be able to stage anything. It just doesn't work. So this is from November, the 11th of November. It says she has ovary cancer and she is 57 years old. So let's look for, there is a small gastric herniation. They went almost all the way through the chest. Why? I don't know. Go figure. Yes, there is some huge heterogeneous mass on the pelvis. It mixes up with colon, gets mixed up with colon, the uterus, maybe the ovaries. I don't know what this is, because there is no contrast enhancement, and I'm really not going to waste time trying to guess. This isn't the kind of guesswork I enjoy practicing. So just going to describe it as a huge mass on the pelvis. There is some free fluid, so a small ascites and some calcifications, and colon is right there, rectum is right there, and some aortic calcifications, gallbladder, pancreas, and spleen, and whatnot. So just that same old crap when people don't care enough to do a proper scan. They do whatever they please, and they send over for report, and we sent back to them as much information as we can probably guess, because we can't really be sure of anything in such horrible scanning conditions. So this is an older scan. The gallbladder was closed up, was contracted, was reduced in volume. There is the same mass right there. Bladder was yet again reduced, partially filled up. There was the same free fluid on the pelvic cavity. This right there, this is free fluid. So a small ascites, and there are clear signs of constipation. Of course, because there is a huge pelvic mass, it's supposed to be very difficult to defecate. clear signs of ascites right there. And it's quite the same exam. Can't really say much difference. There is much difference between the two. Just couple of useless abdominal CT scans that help no one, but the hospital make a bunch of money. So let's just report one of those scans and we just copy and paste to the other because it's really just the same. Besides the gallbladder is voided, it's partially voided on the old scan. Just going to put a phrase at the top of the report saying it's really difficult to evaluate the images because there is no contrast enhancement. Because if this patient turns up to have a full-blown hepatic metastasis and all over the place as soon as you inject contrast, and we are able to see all kinds of secondary disease, they are going to mention that the previous CT scans were all normal and those metastases aren't supposed to be so big and so severe if the last scan was apparently normal. So I have to make clear on my report that this scan isn't enough to do a proper cancer staging on this patient because there is no contrast enhancement whatsoever. So it won't help much, but it's just what I can do for the time being. And I could just sip some coffee and curse on my head, in my head, as I report this piece of crap. And this is it. Just going to report that huge mess on the pelvis. Not going to, just 10.6 to 11.1. And this is it. Just going to copy and paste this first report to the next one. Just fix right here gallbladder, that is normal in this setting, in this newer exam. And Going to do a follow-up footnote. Follow-up footnote. It's really the same. No changes whatsoever. And we are good to go. Let's leave this behind us and grab another scan that we could properly diagnose anything of use. It's a head CT scan, 82 years of age, male patient. It says he had a stroke 20 days ago. So stroke patient, 20 days. It's considered a subacute. I guess it's a subacute stroke. Indeed, there is a scar. There is another stroke scar right there. I suppose this is subacute. Indeed, it's kind of large. This is left posterior cerebral artery territory, so this is probably caused by that. So diffuse carotid atherosclerosis. There are clear signs of brain atrophy, moderate dilatation of the ventricular system, 2 small lacunar strokes on the left thalamus and basal ganglia, pretty typical, and of course another stroke, subacute stroke, right there on the left occipital lobe. Nothing fancy, just an old man and his collections of strokes. I have a template for this, of course. This is quite common. Quite common indeed. So there is diffuse hypoattenuation, diffuse white matter hypoattenuation. This is usually related to white matter disease, microvascular white matter disease, the same disease that leads to this kind of small strokes. And this is another story altogether. It could be related to small vessel disease, but this is usually thrombosis or occlusion of a segmental artery. So it's, at the end of the day, it's quite a similar disease. It all comes from diabetes and hypertension and cardiovascular diseases not properly treated. So it's moderate, also moderate dilatation, moderate hydrocephalus, and let's describe the strokes. So this is it. Let's see how the transmission is fine. It says here Just, yes, it says healthy, so it's fine. Great. Now the stroke, the neuro stroke on the left occipital lobe. See. Oh, left occipital lobe stroke. Just going to summarize it, make it easier for the referring physician to read my report. So, moderate and moderate right there. So we are done. Just, it's all gone. Let's go for a CT scan of the abdomen. It's kind of slow today. It's here. This patient, it's a child, a small child, a female child, 6.5 years of age, and it's to look for intestinal obstruction. It says they gave her oral contrast. I don't know why. It's stupid. You're not supposed to give anything for a child to drink or eat if it's a suspected intestinal obstruction. If the child can ingest a large quantity of contrast, it's clearly not obstructed, so what's the point, right? And they do no intravenous contrast enhancement, which could actually help us diagnose anything. So they make the patient take the wrong type of contrast that is even deleterious, it could even do harm, and they scan the patient without proper contrast enhancement, which could actually turn out to be useful for any kind of diagnosis. I can see there is a large quantity of feces on the rectum and the colon, especially the left colon, the sigmoid. There are no signs of intestinal obstruction and no signs of nothing besides that. There is the appendix right there, it's normal. So this is one of those useless CT scans of children. So we're just going to report it and be on our way. Because it's useless to just waste more time bitching about this. Just going to report it and forget about it. Gallbladder is fine. Yes, it is. And right there. Appendix is normal. Not going to say anything about lymph nodes. Uh, Just too much feces on the rectum. Right there. I don't know how you call that in where you guys are. Maybe you could leave that on the comments, but here in Brazil we call this Fecaloma. I suppose it might be called a Fecaloma, a fecal, a feces tumor, a large quantity of feces in the rectum and in the sigmoid colon right there. This could be quite painful, especially in children. So it's done. Let's grab another abdominal CT scan just because they are fun. And let's wait a couple of seconds. Yes, it's here. It's downloading. It's a male patient. He is 66 years of age. Let's see if we can figure out why this exam was made. It says this is a contrast enhanced CT. This patient has prostate cancer. He is going through chemo. And he had blood in his urine, and he isn't able to pee properly for about 1 week. So I have a template for such cases. I'm just going to copy and paste my template, and we are going to dive in this case to see if we can properly diagnose anything. So if he is going to chemo for prostate cancer, I suppose he has advanced stage disease, because usually there is no need for chemo for prostate cancer if it's early stage. Usually early stage is just surgery or radiotherapy. No need for chemo. So yes, it is an incomplete scan. I can't properly evaluate this because they didn't send over the entirety of the scan, just have the images. Just for you guys, there is diffuse secondary enlarged lymph nodes. There is a huge mass inside the bladder. Probably this is tumoral or blood, maybe both. There is ascites, other bone lesions, probably yes. Probably there, probably not, but this is clearly end stage disease. Large lymph nodes right there. I can go up because it's incomplete. It's a incomplete diffuse disease right there. Edema, probably some sort of venous thrombosis related to enlarged lymph nodes, pelvic lymph nodes, like that. So this is one of those cases, and of course they didn't send the exam in its entirety. Just going to send it back and grab the next one from the list. It's another CT scan of the abdomen. It seems we have a full queue of CT scans, and it says they are emergency scans, but they are clearly oncologic scans that were delayed, and for some reason they are paying extra to go through the emergency queue. which is bad because it's kinda tough to deal with oncologic patients in a quick and dirty setting just like this. This is yet another cancer patient. It says his abdomen is distended. He is 69 years of age. I mean, it's a she. It's a 69-year-old lady. So, there is a large stenosing colon, sigmoid colon right there, stenosing lesion right there, and there is diffuse dilatation and feces accumulation on the rest of the colon all the way to the cecum and the ileus right there. This is the appendix. It's normal. The bladder is fine. There are bilateral hernial inguinal hernias or herniations. I suppose someone took her uterus out. There is a small ascites, maybe moderate ascites. Yes. And liver seems fine, although we have no contrast enhancement because this is one of those exams. Not going to waste much time on this because this isn't a properly done exam. This is just make-believe, just one of those make-believe exams. There is some sort of lobulation on the top of this left kidney right there. Some atherosclerosis of the aorta. Adrenal glands are fine, pancreas seem fine, but the main cause of complaint for this patient is this large stenosing lesion right there. It's on the hypogastrium, deep inside the pelvis, and it's 6.5 centimeters in extension in the longer axis. So this is what I'm going to report. And let's see if we can see some enlarged secondary lymph nodes on the retroperitoneum. No, not yet. Not without contrast enhancement. But they don't seem to care because this is what they gave us to work with. So let's just quickly go on and dismiss this with a report and go to the next one. See if we can properly help someone today. 3.8 on the superior pole of the left kidney. This is hypoattenuating, heterogeneous, and really odd. I don't think this is a regular cyst. Might be a tumor, but clearly no one cares because they did it without contrast enhancement. This is how big it is. It's 3.8. Yep. Partially filled bladder. I couldn't really say there is much left of the uterus. Can't really see it. Might have been taken out. There is moderate ascites, moderate increased intraperitoneal fluid. Supposedly this is secondary to the tumor, already taking part of the peritoneum. So this is advanced disease, as most commonly it is. So this diffuse dilatation of the colon and the ileus is due to this right here, this stenosing lesion right here. This is a tumor, the most common presentation of colon cancer right there. So colon cancer, stenosing, obstructive colon cancer, sigmoid colon cancer. And that's what we are going to report. I have already reported. I'm just going to summarize it. It's going to say it's of limited evaluation because it lacks contrast enhancement. This isn't a proper staging exam because we can't say for sure if there are liver metastasis, spleen metastasis. We can't properly delineate the retroperitoneal lymph nodes and all that good stuff. There is also a small hernia right there, a gastric hiatal hernia. Just going to report that in. Let's go for a is there aortic calcification? Yes, some calcification right there. And so there you go. We have described it as much as we can. The case of cancer. This is cancer. It's just as bad as it could be. Of course, why not? So let's grab another CT scan of the abdomen. Hope it's not cancer because it's just really tiring. I'm just get fed up with cancer patients really quickly these days. I've gone through this way too many times. I don't have that patient I used to have back when I was just a young doctor going through endless piles of CT scans. Just wait up. Yep, it's here. This is contrast enhanced. Hope there is a reason for this. This is a 45 years old female patient. It says she has acute and strong pelvic pain and might be some kind of pelvic cyst on the right and ascites. So I don't know. Let's see what we can tell. I have a template for this, of course. Right there, template is set. Let's scroll down. Liver seems fine. There is a moderate ascites indeed. It's looks like fluid. Contrast timing is wrong, but it isn't the end of the world. It's just wrong, as most of times it is. There is some kind of cystic lesion right there on the mediastina, which I'm going to ignore because this is a abdominal CT scan, not a chest CT scan. So settle down, not going to report it. If they want a chest diagnosis, they can always order a chest scan. Oh, this is something. I have no idea what this is. This is some bizarre cystic lesion right where it was supposed to be the right parametrium. Usually this is related to some sort of reminiscent, some sort of Adnexal mass, some sort of fallopian tube or ovary that was left behind when they took out this patient's uterus. So there is no uterus, this is just fluid, and there is this odd looking partially cystic lesion right there. I say it's partially cystic because it clearly has fluid attenuation 25, and it only enhances on the walls. So there is enhancement right there. See, no enhancement here. There is, see, from 38 to 51. So these are either a solid component or a thick wall, which makes this lesion a very good candidate for a exploratory laparotomy. So there is also thickening of the bladder walls and diffuse edema of the fat tissue inside the pelvic cavity. So this is an acute setting of some sort, probably a torsion or a infection, some sort of inflammatory response to this thing right there. Liver is fine, spleen is fine. There is moderate ascites, moderate, diffuse edema of the intracavitary fat of the pelvis, and that huge lesion right there, which is 9.8 by 5.7. Just going to grab another measurement on the MPR. So the surgeon will be fine. On this, we can clearly see there is a solid part and a multiloculated thick-walled lesion right there. So this is probably of ovarian origin, if I would take a wide guess. Probably a tumor of some sort. So let's just report it and get on with our lives, because there are a ton of other scans that just won't report themselves. So just taking this off. Are there enlarged lymph nodes? Yes, some enlarged lymph node right there. Interaortocaval right there. Subcrural, precaval, para-aortic. So there are indeed a bunch of lymph nodes, both on inflammatory settings and in secondary metastatic disease. We are supposed to see such lymph nodes, so it really isn't much, but it is something. So I'm just going to stress that out on the report. Let's see the gallbladder. Always check twice or 3 times for gallbladder disease. No gallbladder disease. There is some inflammatory response on the bladder itself. Did you guys see the appendix? Oh, this is it. Appendix itself seems fine. It looks inflamed because it's all inflamed. Everything is inflamed around it, but it is indeed it has some thick walls, so I'm going to report it as enlarged. It might just get taken out together with this large lesion right there. So I'm just going to summarize it. So it's just that. Lymph adenomegalies, lymph node enlargements. Yes. Just checking to see if I missed something. No. It's all good. It's all fine. So just say it's critical, just to give a heads up to whoever is going to receive this report. Yet another CT scan of the abdomen. Now it's a male patient. Let's download it. It says the patient, it's a boy, a teenager, 15 years old, and it says he has a palpable mass on his abdomen and has lost some weight, and he has some asymmetric left lower limb edema. It says he has been through biopsy and it was diagnosed as cancer. It really doesn't say which kind of cancer it is. It says he is going through some sort of oncologic treatment already, but they of course did it unenhanced. Yes, they did an unenhanced CT scan for the abdominal mass in a patient that is going under cancer treatment. So there is a mass. I can't really say much. It's just there. It's all a very large gray blur. This isn't a proper exam. It's just a scam. You're just scamming the patient and the family to get money from them, because you can't really do any kind of diagnosis like this. Just going to be clear on the report that I can do a proper diagnosis because there is no contrast enhancement whatsoever. So first phrase of the report is just that I can do a proper diagnosis without contrast enhancement. It's a 22.5 partially necrotic mass that occupies most of the inferior quadrants of the abdomen. So it is what it is. I don't know, is there ascites there? I can't really tell. Patient is really thin, it's really sick. There is way too much soft tissue edema. Can't really tell if there is ascites or not. Maybe there is some sort. I don't know, is this colon? This is looks seems to be colon. Not free fluid. There must be some sort of free fluid like that, because between, yes, I'd say it's moderate ascites. I can't really say. Is this the bladder? Might be the bladder right there. It's really difficult to just say. And there is necrosis, there is emphysema, air fluid levels, and some sort of calcifications on the mass. And it's 22 by 0.5 in its larger diameter, larger axis. Excuse me. Right there, large mass reported. This is probably some sort of acute venous thrombosis due to the mass, but I can't really say because I have no contrast enhancement. It's just that bad. There is diffuse distension of the stomach, the bowel, and the colon. I'm just going to report that as well. And we are done. This is as much as we can go. Not going to cry over that. They said there was a correction for me, but there is none. But there is none. Let's just go to the next exam in line. It's a left forearm. Right there, left forearm. We are about 1 hour and 23 minutes in this live stream. If you haven't already, just hit that like button and consider subscribing to the channel. Let's see if we can make these live streams less of me speaking to myself and more of a community interacting on the chat, and we could talk about anything more interesting than just scanning through CTs and MRIs like this. I have a template for forearm. This is probably some sort of oddity. Let's see what they say here. This is this exam is supposed to be. It says there is an infection related to trauma, and they specifically said the exam should be done without contrast enhancement. So if you know a patient has some sort of infectious disease and you order a CT scan and you say they are not supposed to do it with contrast enhancement, it means you don't want a proper diagnosis, because it's simply impossible to be done. This is just a bone window. It's supposed to be a soft tissue window and a bone window, like that. Just going to try to download from other entries from this patient. Let's see if we have a bone. And this is so bad, really. It's really bad, really. I don't know, people just make an effort to do stuff as wrong as they can, and it's really an incomplete exam. Exame completo. Just going to send it back because there was no soft tissue reconstruction available. It's incomplete. You can't evaluate soft tissue without the soft tissue reconstruction. Next up, it's, I guess, a chest CT scan. Yes, chest CT scan. 73 years of age, female. I bet it's non-enhanced. And it says here, let's see, it says nothing. And on the other stuff they scanned, it says it says nothing. Yeah, nothing. It's just a guesswork exam. So we are supposed to guess the motive for this exam and make some sort of diagnosis out of it. Just the regular everyday life of a diagnostic radiologist. Just this stuff. I have a template for this, of course. As you guys know, this is clearly malpositioned. Patient is crooked, has one arm down and one arm up, so this is really badly scanned. Patient is huge, very obese. She has gone through open chest surgery, has a huge heart and a pacemaker on the right. She is old and very obese. There is a massive enlargement of the left side of the thyroid right there, partially calcified, and it's going down into the superior mediastinal. So this is a diving thyroid enlargement in a free form direct translation from Portuguese. Enlarged heart, pacemaker right there. There are small pleural effusions on both sides. aortic calcifications, vascular calcifications, stents. These are coronary stents. There is atelectasis of the left lingular region, atelectasis of the middle lobe, and partial atelectasis of the lower lobes related to the pleural effusions. Also, we have a indwelling catheter. No, it's the probe. It's just the Pacemaker probe right there. It's not a vascular catheter, it's just a probe. My bad. And of course, we have arthrosis and the metallic suture of the sternum, which is just very common in this age. See the stents, it looks in this case really like a stent, not like a regular calcification. Most of times we can't properly tell if it's just calcification or if it's a stent going through a calcified coronary plaque. Breast tissue seems symmetrical, axillary regions seem fine, so we don't actually have an acute pulmonary disease as much as we can tell, just probably a congested lung and pleural cavities due to a enlarged and insufficient heart. Just reporting it quickly so we can go on to the next one. Enlarged heart. Other mediastinal lymph nodes? No, but there is a diving thyroid into the superior mediastinum. Goiter, diving goiter. Let's see if this is a thing. Diving goiter. Is there diving goiter? Thyroid goiter. It's supposed to be. I don't know if this is just a direct translation from Portuguese. It's also called a cervical mediastinal goiter. So it's a goiter, a thyroid goiter that dives into the mediastinum. It's a really common presentation of thyroid goiter in these huge, obese, and old patients, mostly women. It's really, really common to see such presentations. See how the trachea is displaced to the right and kind of deformed. So it's really, really common. It's one of those things you see once and you just can't unsee. And every time you scan through a CT scan or a neck scan, you are always trying to find it once again because it really draws your attention to itself. And once you have described it And as soon as you describe it once, you just take that description, tweak it a bit, and use it everywhere else. So I have a bunch of phrases that I'm used to use to describe the most common or most of the common disease I report every day, since I report over 1500 exams every month. So I have like a quick access library in my head of descriptions of most common diseases that can be seen on CT scans and MRI scans. It just comes right instantly, and I just type it in and I move on to the next one. It's just same old stuff every single day. Enlarged heart. And I guess we're done. This is it. No acute pulmonary disease, at least not something that we could call a pneumonia, just atelectasis, and those small effusions, which are probably related to some kind of cardiac imbalance, cardiac overload, because this patient's heart is really sick. So let's grab a head CT scan of a kid. This patient is a male patient. He is 11 months old, less than a year old, and he has gone to some sort of head trauma. I'm downloading the images as we speak. It's a very slow download. I hope it gets better, because this case it's impossible. Oh, it's here already. So it's a head CT scan for trauma. So we are going to look for fractures. Look what they did. They made someone hold the kid's head on top of the head, right where they scanned the brain, because who cares if the exam is filled up with artifacts? It's just, and it's still shaky. So it's just a freaking useless head CT scan. Why do I even care? See? What the? This is just motion artifacts all over the place. We can't properly say if there are facial fractures or skull-based fractures, because it's all freaking blurred. Half the skin is lost, and if there is small signs of brain hemorrhage, we just can't say, either because it's blurred and shaky and filled up with this sort of artifacts right there, which can just simulate blood, acute blood. So it's really a useless scan. You can really make nothing out of it. Besides, there is no sign of gross disease. There is no bizarre hematoma, but the small disease, the fine grain detail, it's just lost because they made, for some reason, they made the parent hold the kid's head, and the parent, of course, didn't hold it properly. Just artifacts of all sorts and kinds. It's just yet another stupid, badly scanned computed tomography exam. Just one of those. Just going to take out the phrase that says there is no signs of acute hemorrhage because I can't really tell. And I'm going to put in a right on the top of the report a phrase saying that it's the evaluation of this exam is very limited due to a bunch of artifacts of all kinds. So let's just this is what they want. They want a report just to chart the patient. They really don't care much if the exam is really useful for any sort of diagnosis. They just want the money, and they just send in a scan that has no images on it. Just going to confirm it. Oh boy, it takes so long to open up an exam. It's just really slow. Okay. Let's see if I can download this. It's trauma. It's a 75-year-old patient. It seems she has gone through some sort of trauma. It says here it's 0 images, but there are much more than that because it's a 58 meg exam. So it's not really 0, it's just typed in wrong. So it's a CT scan, diffuse reduction in brain volume, enlarged fissures in sulci, mild dilatation of the supraventricular supratentorial ventricular system. Fourth ventricle is fine. Also reduced cerebellum. Brainstem is fine. Diffuse calcification of the carotids. It says trauma, but I can't really tell. Doesn't seem to be a trauma case, not a major trauma case. Just going to put a bone window right there and see if we can see any gross fractures or deformities on bones. Mastoids are fine. Zygomatic arcs also fine. The base of the skull seems fine. Orbits, nothing major. It's shaky, but bones seem okay. The nose isn't fractured. Maybe there is a tiny fracture of the nose, but there is no thickening of soft tissues, which is odd. So I'm not going to report that. It seems fine. So there is some slight hypoattenuation of the white matter, very light, very ventricular hypoattenuation. This is microvascular disease, a slight dilatation, hydrocephalus, supratentorial hydrocephalus, and diffuse reduction in brain volume right there. This is really common for a 75-year-old patient. No signs of major trauma. I'm just going to grab my template right there. Template, it's here. And just fix it up and finish this exam, because it's no use to be around this. It just says trauma, so it's trauma, and we have seen no signs of major trauma, so it's normal. It's normal, it's done. So guys, it's been a very nice 1 hour and 45 minutes. I have BJJ practice in a few minutes, so I'm going to get ready and go be beaten up for over 1 hour straight. And I hope to see you guys tomorrow. I'm streaming tomorrow morning. I'm just going to set up the next stream and send a notification to everyone that is subscribe to the channel. And of course, if you are watching this video to the end, I'm very thankful to you. I really appreciate it. Consider subscribing to the channel and leaving that thumbs up and sharing this live stream with people you know enjoys radiology, diagnostic radiology as much as we do. Thank you so much, and I'll see you guys around. So long.